Can anybody hear me?
Oh, it should be okay. Maybe a little closer.
Hello? Hello? Oh, good. You can't hear me. I think a few more people will be coming in, but I wanted to make sure that we started while there's a quorum here, or maybe even not a quorum. So thank you all for coming. I think many of you know that this is the 14th annual Marshall Seidman Lecture, and the mic's not on. Is it on now? Okay. I think many of you know that this is the 14th annual Marshall J. Seidman Lecture in Health Policy. And this was given by Marshall Seidman on the occasion of his 50th anniversary from Harvard Law School. And the fact that he gave money to us, we thought was quite a big deal because the law school really wants his money, or wanted his money. But obviously for a 50th anniversary. But he met with me several times during his reunion and then after the reunion, and he decided that Harvard Medical School and healthcare policy were the perfect places to support research and education in a variety of areas regarding costs and quality of healthcare. And he was particularly interested in both of those aspects as they applied to federal and state policy. I think many in this audience, particularly those in HCP, know that Marshall attended the first 4 of these Seidman lectures and always sat right there. And he always wrote to me afterwards and he said these were the highlights, these lectures were the highlights of his year because of the quality of the speakers. And I think if Marshall were alive today, and he died about 5 years ago, he would be thrilled with today's speaker, wherever she is. Oh, there she is. And as we all know, hospital mergers and acquisitions have risen to the front pages of almost every paper in the country. And I think locally we have to just think about Partners and South Shore and Hallmark and whatever to realize how important a topic this is. And I'll just tell everybody right now so you can sit glued to your seats that at the end of this talk I'm going to ask Stuart Altman to say a word about what happened at the hearing today related to the Partners merger. So hang in there. So she is no stranger to the Boston-Cambridge area, having graduated summa cum laude in economics from Harvard College. She worked as a consultant for McKinsey for a couple of years and then returned to Cambridge to obtain her PhD in economics from MIT. She joined the NBER, with which many in this audience are associated, as a pre-doctoral fellow, and continues her work today as a research associate in their program on aging and healthcare. She's a faculty member at the Kellogg School at Northwestern, a board member of the American Society of Health Economics and the Healthcare Costs Institute, and a member of the panel of health advisors of the CBO. And most pertinent to today's talk, and one of the real reasons that we were so excited to get here was her experience from 2012 to 2013 when she served as Deputy Director for Healthcare and Antitrust in the Bureau of Economics at the FTC, hence the excitement about the timing of today's talk, which I have to tell you was not dumb luck, it was careful planning. So she holds the distinguished position of Professor of Management and Strategy and the Herman Smith Research Professor in Hospital and Health Services at the Kellogg School of Management at Northwestern. She's won a number of teaching awards, including Kellogg's Leading Research Prize, the Stanley Writer Best Paper Award. And you can see up here the title of her talk today, so I'd like all of you to welcome Leemore Dafney to the 14th Annual Marshall J. Seidman Lecture.
Thank you so much for that. Is my mic on? It's on. Okay. It really is an honor to be here today at Harvard Medical School. And thinking about coming here, I was reminded of some lessons I learned my first few days at a Harvard campus. I went to Harvard College, as Barbara mentioned. And you learn a little bit about the characters of the different schools. As you know, Harvard is very decentralized. So you learn that the very best gym on campus is definitely at the B School. That would be Shad, and if you're an undergrad, you're never getting in. If you want to meet a future politician, you head right up to HLS. Okay? And as smart as we might think we are as undergraduates, the smartest kids at school are at HMS. Okay? So we know the pecking order, so I'm especially honored to have the chance to address you today. Right. Well, let me start by explaining why I think this is such an important subject, and I'm so glad that so many of you agree. Well, we had a choice in 2010 when we passed healthcare reform, and we chose to build on the private sector. Okay? And we could have gone some other way, but we didn't do that. We decided, no, we believe in markets. We want competition to work. We're going to subsidize the purchase of private insurance. We're going to continue having private provision of healthcare and so forth. And in order for the markets to work, you need robust competition. Competition usually requires competitors. And back in Ec 10, okay, Ec 101 for the non-Harvard undergrads around here, we learned that in order to have robust competition, you need many small buyers and sellers. Okay? In healthcare, what we're seeing is actually consolidation. Right? And not many small, but very much a coming together. So what I want to do during my time with you today is to try to lay out some of the facts about consolidation, what's happening, where it's happening, what we know the effects to be, okay, for where we know things, then address a series of myths largely related to antitrust enforcement, that is when regulatory authorities enforce competition law, okay, and also a myth about the Affordable Care Act, and then at the end to close with unknowns, okay, which could absorb the discussion after. I'm certainly planning to allow plenty of time for Q&A. So that's my plan, and I'm really looking forward to our discussion after. So facts first, and what you do with them, that's up to you. All right, so let me start because this is a mixed audience. I want to make sure we're all on the same page. Many of the terms that we use to describe integration emanate from the vertical chain of production. So this is actually a copy of the vertical chain of production that I've used at Kellogg, the business school, when I teach this to MBAs, and it's for branded soft drinks. And as many of us are aware, the #1 input into branded soft drinks is corn syrup, for those who don't drink diet at least. And then that input goes to the concentrate producers, for example, Pepsi. They mix it with their secret stuff. They send it down to the bottlers, okay? And then distribution takes place. Oftentimes, these are the same entities. Okay, so they're consolidated, then goes to the retailers, and that's for local flavor. We don't have Stop and Shop, but I think you still do, right? Okay, Stop and Shop. All right, so why did I put that up there? Just to say that when I talk about consolidation or integration and I say vertical, it means up and down the supply, the vertical chain of production, okay? Whereas horizontal consolidation would mean that there are multiple suppliers who in the same chain, okay, the same step of the process are combining. Okay. Now that is more black and white than we have in reality, but let me give you a couple of examples. So horizontal, classic one would be hospital merger of general acute care hospitals in the same geographic area. Vertical would be, a simple example is pharmaceutical companies who combine the research and development arm of their business with the marketing arm of their business. These things don't have to be combined, but they are vertically integrated. Okay. And lateral is a term often used for anything else. It could be conglomeration. It could be multi-specialty groups. In reality, often these things are just termed non-horizontal, where horizontal refers to, similar types of competing entities serving the same set of end customers, and non-horizontal is other stuff. Okay? Let's take a complicated example. This is very common these days, hospitals acquiring physicians, and probably physicians here don't like me to use those terms, so I mean signing a professional services agreement and with your practice. Something like that makes it sound less like indentured servitude. So that has a vertical component, right? The physicians are the sources of referrals to the hospital. Okay? But it also has, and this is seldom really noted, but is very significant when it comes to interpreting whatever research is out there on this subject, it also has horizontal components. So oftentimes the hospital is acquiring many, many physicians at once, perhaps in the same specialty, therefore amassing some horizontal market power as well. And therefore, if you're trying to look at the effects of vertical integration, if you're mixing these two things, you're going to be mixing what you're studying. Okay? All right. Some motives, I think, are very significant here in thinking about the value of, hopefully that's not my phone, in thinking about the value of these transactions. So I wanted to start with just a very straightforward example. The shift from a solo practitioner to a group medical practice, same specialty. Okay, so very basic, classic thing. You could think of some motives for that being reducing cost or improving quality. Lots of economies of scale. You can have the same receptionist. You can have one physician assistant setting the rooms up. You could also potentially, if you have a large enough practice, support a registered nurse who can then help you keep tabs on your cases that require follow-up, thereby improving quality. These are maybe, let's call them good reasons to consolidate. You could have better purchasing power in some cases with respect to your supplies, right? Others, and raising price is not all bad. This is the only bad one, okay? You could engage in some practices facilitated by the scale that actually improve the value of the product or service that you're offering and thereby enable an increase in price, and that's value creation and then charging accordingly for it. So I think of the pediatric practice that I used to use in downtown Chicago, where they had many, many pediatricians, and there was one who specialized in sleep training. Anybody who's ever had a child understands why that would be a specialty. So one specialized in sleep training, another one in behavioral disorders, another one in growth, and the fact that they had this multitude of pediatric experts in one location presumably enabled them to be included in networks and at more favorable pricing. I did not grill my physician from there on that, but maybe I'll get to it soon. All right, an alternative way to raise price is just eliminating the competition. Where else is are your patients going to go? If say, the vast majority of pediatricians are with this downtown practice, that enables you to exercise market power and raise price, or equivalently cut your quality and hold price constant. Make patients wait, don't have those walk-in hours, and don't call them back as quickly, and so forth. Okay? And then increasing quantity, which could be an objective for a horizontal combination. Now, just adding up physician practices or adding up ambulatory surgery centers, that doesn't increase quantity, that just puts them under one corporate umbrella, right? Increasing quantity could be accomplished by reducing your cost and therefore being able to lower your price and still increase your total profits, or having a greater product variety or improvements. All right. You're getting lucky because I have a great clip for vertical integration. A few in the audience have seen it. But let me first mention that the motives for vertical integration, remember thinking up and down the value chain of production, they are a little bit more subtle. Okay, this is all about aligning the incentives of the different producers along this chain of production, okay, which we all know to be very complex. We've all heard a lot about ACOs. And some of the objectives of vertical integration include things like making sure that everyone in the chain has the optimal incentives to make investments in the relationship, which can be difficult to do if they don't have a strict joint venture or aren't in the same organization. So to take an example, think of when I mentioned pharmaceutical companies. Okay? If there is a pharmaceutical company that does the R&D and, say, outsources the marketing, imagine like they outsource clinical, some of the research, suppose that they outsource the marketing. Well, those marketers, that might be efficient to use the market in some ways because you only hire them when you need them, et cetera. But they will not make as great an investment in your drug as your co-owned marketers would do, because next year they might be pushing your rival's drug. Right? So their credibility and reputation and investment is going to be affected by what they do. Okay? So motives for vertical integration for, say, integrating into your own marketing include the belief that there are some synergies from that and some investments that wouldn't otherwise be made. And a synergy could be your marketing people feeding up to you. You thought that making it subcutaneous wasn't so bad, it's so bad. Right? So there are feedback loops that you might be able to achieve through some form of vertical integration. But really, I cannot say it as well as Alec Baldwin. You can't blame me for that.
The hearings on the Cabletown NBC deal are underway, and the company has entrusted me to be their front man.
Hey, will you ask Congress where they put the USA Network? I've been trying to find Monk for like 3 months.
The only thing I will be discussing with the House Subcommittee on Baseball, Quiz Shows, Terrorism, and Media is vertical integration.
What's vertical integration?
Imagine that your favorite corn chip manufacturer also owned the #1 diarrhea medication.
That'd be great, because then they could put a little sample of the medicine in each bag.
Keep thinking.
Except then they might be tempted to make the corn chips give you...
Vertical integration.
Wow, that should not be allowed to happen.
But it's my job to make sure that it does happen.
Yes, it's great. It's great. So let's talk about some of the numbers, all right? I promised you the facts first. I won't get to distorting, hopefully at all, and if so, closer to the end. So hospital mergers are on the rise. This is data that we cleaned up from Irving Levin and Associates, who commonly report these transactions, and it's just for general acute care hospitals. So if it looks a little smaller than some other numbers you've seen, we're just talking about acquisitions of general acute care hospitals. And you can see after the 2001 recession, there's a decline. Then it's somewhat stable, maybe increasing slightly. And then after the Affordable Care Act, there's a surge in hospital mergers. And if we had more recent data, we would see that increase. Part of the reason that the FTC brought me in was that in the wake of the ACA, they had already had half their caseload was in healthcare, and they were seeing more transactions coming. And so I got this phone call from someone that I did not know saying, I'm going to be director, and I'm told that I really need to have somebody who knows about healthcare deals in the front office. I didn't know what the front office meant, but it means you don't do any real work. All right. I'm not kidding. And I don't think I've worn this suit since I was there, because I'm not in a suited job anymore, but I was then. So here I could plot a number of facts for you from these data, but here are just a couple that I found pretty interesting. So this is the number of independent hospitals since 2000. It's just continuing the steady decline, possibly accelerating a little bit in recent years, down to about 42% of hospitals are independent. That is, they have no partnership, that is joint ownership with any other hospital. Okay, another one I thought was really interesting to look at is the number of hospitals that are part of a system that has 5 or more hospitals in the same state. Okay, so these are, and you could try different market definitions, but within state systems that have significant presence within the same state, and now 1/3 of hospitals belong to that category. And of course, if you weight everything by the size of the hospital, these trends are going to be more pronounced. All right. And other providers are consolidating too. We know physician practices are getting bigger outside of hospitals. We know the hospitals are acquiring through professional services agreements, are acquiring the physicians. And this is the most conservative number I could find. I wonder if you could guess who would report the most conservative number. Kind of given away on the slide, I guess. Now, the American Medical Association, maybe that's an inside joke, David laughing. The American Medical Association has the lowest number I could find, says 29% of physicians are directly employed by hospitals or are in practices that are hospital owned, and I don't know whether wholly or partly owned. Other sources have this figure going upwards of 40%. Right? So that is certainly a form of horizontal consolidation, right, as well as vertical integration and consolidation. I put up a couple of other industries with which I have some knowledge. These are not the only ones, but in fact, there's a real shortage of data out there on some of these other non-hospital, non-physician. Frankly, there's a shortage of physician data, but there's a shortage of data on these other organizations, which is something that folks in this audience are looking to address. Okay? We know in the dialysis industry, something that I have jointly studied over here with David, that industry has become very concentrated. It's a duopoly. DaVita and Fresenius are the names of the players, multi-billion-dollar industry, lots of profits, fairly poor quality and poor outcomes, I'll talk in a moment about the relationship between these outcomes and integration. And then another example is long-term care pharmacies. These are located in skilled nursing facilities and other assisted living facilities, and that's highly concentrated. And I'm sure that there are others. That said, there are other industries that are fairly fragmented nationwide too. Okay, just so that you don't think I'm picking on providers and I haven't been accused of picking on providers publicly, but I have been accused of picking on insurers. So let's pick on them a little bit. That industry is pretty darn concentrated, right? And has only become more concentrated. This stat is a little bit old, 400 mergers between 96 and 2009. There's some recent mergers. Aetna and Coventry merged. There's been some acquisition of Medicare and Medicaid managed care plans. So some acquisitions are still going forward. More than half of metropolitan areas in the US are served by an insurer that has at least half the market. I paused for effect. That's huge, okay? That's huge. I said this publicly, that if you're an insurer who wants to merge, now is a better time than it has been in other circumstances, because if you're proposing a merger, and these are really, it's very fun to be on the sidelines when parties are proposing mergers and you're listening to the arguments. When parties are proposing a merger, one of the things they tend to argue is, look, we're going to do lots of great things. We're going to reap all kinds of efficiencies. And even if we wanted to raise price, if we tried to, other entrants would come in. Okay? Or our rivals would raise price, but even if they wouldn't, the barriers to entry are fairly low and other entrants would come in. Well, that argument carried no weight in the insurance industry until very recently. So now's a good time to be an insurer seeking to merge, because we have seen new entry into the health insurance exchanges. By my count, 33 new entrants, including 13 co-ops, which are of varying financial solvency. But there has been entry, and it's not just by co-ops, it's also by provider plans, it's also by plans that serve Medicaid enrollees, and for the first time are starting to serve the individual commercial market. Okay, I wanted to leave this blank for effect and say we just don't know that much about vertical integration trends. So let me say that. We don't really know that much about vertical integration trends. There's some research out there. Mike McWilliams here is doing some of it. But it's fairly limited. We know some about hospital physician acquisitions. And so I just want to give you a couple of examples to make clear what it is that I'm talking about. So there's partnerships between DaVita, the big dialysis chain, and Healthcare Partners, large operator of physician practices and clinics out in the West. There are combinations or joint ventures. And by the way, right now I'm talking about all of these in the same category, JVs as well as outright acquisitions. Most recently, maybe 2 weeks ago, Anthem in California announced a really interesting partnership with several hospitals, including Cedars-Sinai and UCLA, and they are arguing they're trying to create an integrated system, but without joint ownership, with a joint venture instead, where the participants all share in the gains and losses if they are incurred, and that this is an attempt to basically tackle Kaiser's stranglehold on that market, where many are attracted to that vertically integrated organization. Okay? So that's an interesting move, and in kind of a risky one, frankly. And then there are other sorts of combinations where providers are combining with health plans. Certainly we've seen some of the insurers go straight out and buy providers. We know some providers have insurance plans. The main one here that got a lot of attention recently is Highmark Blue Cross in Pennsylvania, bought the struggling West Penn Allegheny Medical Center. Some of you are familiar with that transaction. But the notion there's going to be two large competing vertically integrated systems with University of Pittsburgh Medical Center and its health plan competing against West Penn and Highmark, and that's going to start in 2015. So that's a brave new world for them. So there's a lot of action. Okay? Summarizing those trends, and you say, okay, all right, fine, these guys are all getting together, but that might be all right. Bigger could be better. So you know what's the problem here? Is there a problem here, right? Well, the research that we have suggests that horizontal integration, right, leads to price increases and very little, if any, quality improvements. In fact, there are more studies finding quality reductions following horizontal integration. The best available research is from the hospital sector, Okay, but there's also research in other settings, including physician services, and I'm happy to give sites if anyone wants. Physician services, so in counties where physicians have become more consolidated over time, Baker and co-authors find that the prices paid for those outpatient services have risen, and some evidence in the dialysis sector as well that consolidation is associated with price increases. And to mention them again, the insurers, after they merge, appear to increase price. Okay? And that's a topic I'll revisit at the end again, because there are some who believe that if we only allowed the insurers to merge, they would wield market power and then be able to wrest it away from the provider organizations. And I'm looking at you people who believe that. And actually, I will say that. I will say that I imagine in some circumstances that's absolutely true, that the research that I've done systematically has not found that to be true. And the rationale for that would be if I'm an insurer, I merge with another, I have some market power, even if I can use that monopsonistically to negotiate lower prices to the hospitals, right? Why should I pass that on? Okay? And since it's not the kind, we're not doing Q&A, somebody can't ask me about self-insured plans now, but you can later if you want. Okay. All right, what about the vertical, or what I'm calling non-horizontal, because as I said, things get really messy, right? So the non-horizontal integration, the early evidence on that is not particularly encouraging, and I should add to this the early evidence on ACOs, okay, is not as encouraging as certainly we had hoped. So one example is acquisition of independent hospitals by chains. And you might say, wow, hospitals, I thought you said that was horizontal. Let me be clear that in order for something to be horizontal, it has to be in the same market. And for hospital services, most healthcare services, that means it's going to have a certain local quality to it because you only serve patients within a certain geographic radius. Okay? So if a hospital is acquired by a system in, outside of its market, that is viewed as non-horizontal. Okay. The evidence on acquisition of independent hospitals is that prices increase 14 to 18%. I'm working on a study now that compares what happens when you're acquired by a hospital in your own market by a system that has a presence in your own market versus by a system that doesn't, and trying to contrast that, because some part of that increase could be due to having better negotiating skills or introducing different product lines, and I want to try not to confound the different effects that are going on there. And a recent paper by Kate Bundorf and others in Health Affairs, I think is a very important paper that was presented at Cape Cod Conference in the fall, finds that in areas where over time physicians are becoming more fully integrated with hospitals, that those areas experience increase in spending. Okay? And a leading hypothesis for that increase in spending, and certainly something that I learned about when I was at the FTC, is the imposition of these facility fees, or what's also called provider-based billing. The non-technical terms I could use to describe that, basically, you could be a physician, you're not owned by the hospital, your practice isn't owned by the hospital, you make a certain charge, you become owned by the hospital, and now you get to tack on some facility fee. Okay, did I get it right? More or less, I think this is how it works, and certainly the payers have come to express their complaints about this sort of gaming. Okay, I think this is the last real slide of facts before I get into facts, which is kind of a story. Okay, so the antitrust enforcers have been winning. Okay. There was this nice story in the New York Times a couple of weeks ago about the FTC and its successes in hard-won successes in hospital mergers. And I won't force you to hear about all of these, but let me just mention a couple. So I've listed the 4 victories in recent years where the FTC successfully got the parties to abandon this combination in Virginia, Inova, Fairfax, Prince William. In Rockford, Illinois, 2 out of 3 hospitals proposed to merge. In that very same town, some 15 years prior, 2 out of 3, I don't think the same 2 proposed to merge, and they tried it again, and that they lost. The federal government won its attempt to get a preliminary injunction. So let me take a step back and explain what that means, because I did pick up some legalese when I was in Washington. And the way it works is parties propose a merger. And I think later I'll get to talk about how these mergers may or may not be reviewed. But if the federal government or any enforcer, could be state attorney general, objects to the combination and wants to have a trial on the merits or more time to negotiate some sort of consent agreement, then the agency can seek a preliminary injunction in federal court, which means that they say we will be irreparably harmed if this transaction is consummated, and so we need you to pause it and not allow these parties to combine until we've had a chance to settle things. Okay? The standard for getting a preliminary injunction is, in my humble opinion, incredibly high. Okay? So one of the perspectives that I took away from my time at the agency is some might think, wow, these enforcers are so aggressive. They're coming down like tons of bricks and investigating all the time. I'll talk about that myth soon. But to get a preliminary injunction, unbelievably hard. Okay, unbelievably hard. You have to really prove that there is no way out of it but for preventing this from happening right now, and it's very hard to get. Okay, so they won that. This one is interesting. I was at the FTC for this. The two only hospitals in Hot Springs, Arkansas. Okay, little known fact, about an hour from Little Rock. Right, I met with these people many times. The two hospitals sought to merge. Okay. And the FTC kind of kept saying, this is a merger to monopoly in a fairly, defined geographic area. Little Rock is really far away. And after many months and too much money spent on their side, they abandoned, okay? There was another one, which is a specialty hospital. That was kind of interesting. Specialty Orthopedics Hospital in Reading, Pennsylvania, had actually arisen as a rival. Some physicians who practiced at the dominant hospital, Reading Hospital, decided to create their own specialty hospital, I'm sure when there was no moratorium in place, okay? And they had fantastic rates of quality. The studies that they had presented showed that even for the exact same kind of cases, the same sorts of risk factors, that they did quite well. They had improved their processes, so much so that Reading Hospital had publicly stated that they had improved the quality of their care and their patient responsiveness and their patient flow and so forth because of this rival. Well, then Surgical Institute of Reading decided they wanted to sell to Reading Health System, which offered them a very nice deal, and we at the FTC said, okay. And then most recently, this one got a lot of attention because, to my knowledge, it's the only litigated physician merger case. And let me be clear, it's not that other physicians haven't gotten together to try to jointly negotiate, right, which is also called price fixing. But this one is an actual combination that went all the way up to court. All right, the parties didn't settle, and it's pretty rare to actually end up in court. And what happened was the dominant hospital system in Idaho is called St. Luke's, and they sought to acquire, and in fact did acquire, because the preliminary injunction was filed by private parties and they didn't win it, okay? So they did in fact acquire the largest independent multi-specialty practice in the state, which was in Idaho's second largest town called Nampa. Yeah, I know this stuff. It may take me years to forget it. But they acquired, but the thing was that they actually already had a number of physicians in Nampa. And so the combination would lead to their having something upwards of 60 or 70, I don't remember the exact number, of the market share of primary care physicians in Nampa. Okay, which would arguably enable them to exercise market power, raise prices, either for physician services or for any of the services that are part of that healthcare system. Therefore, making it essential for, or the government argued, making it essential for insurers to include all of the St. Luke's system, okay, with all of its hospitals, including the hospital it had near Nampa, in health plans. And the competing St. Al's system, which was not too happy and also filed lawsuit, which got consolidated with the FTC's lawsuit, was concerned about being foreclosed from the market. But the government's case was all about horizontal. It said you're combining too many physicians together in a narrow specialty group, and that is in violation of the Clayton Act. Okay, which I think I have a slide where I'll go over the Clayton Act. So I did a bit of cheerleading for the federal agencies here because they deserve it. They worked really hard and they finally had some successes, but winning is really not easy. Okay? If you are searching for examples, I will gladly talk your ear off about the Phoebe Putney case in Albany, Georgia, which just had a really interesting development. But the main story, and I wrote about this last year, is in Albany, Georgia, again, a merger to monopoly of the two general acute care hospitals was proposed in, I think, 2010. And the FTC sought a preliminary injunction and lost. That merger was consummated. Okay? And then the FTC tried to sue them in order to break them apart, but they were stymied because the parties argued that they were exempt from federal antitrust law because of something called state action doctrine. Are there any lawyers in the audience? Okay, good. Then I'll skirt over the technicalities of this stuff, but they said, you know, law doesn't apply to us because our state is fine with this. Okay? And the FTC had to go all the way up to the Supreme Court just to get the right to take them to court to then have the case heard about whether these two should have been allowed to merge in the first place, and then whether the FTC can impose that remedy of splitting them up, right? And that case is not yet over. And the victories that I told you about were preceded by 6 consecutive losses, which may sound like not a big number, but it is a huge number. So big, in fact, that the FTC and the Department of Justice, they did a self-imposed moratorium. They said, whatever we're doing when we're filing these hospital merger cases is not working in the courts. We're just not going to bring them until we have some new way. Okay? Didn't bring them, and then after some years, they initiated a merger retrospective project. Let's see what happened with some of these mergers that we let through. One of them was where I live, Evanston Northwestern Hospital. So let me tell you a little bit about Evanston Northwestern Hospital. So here's a map of Chicago's North Shore, okay? And this is where Evanston Northwestern Hospital, as it was then known, okay, is located. And they acquired Highland Park Hospital in 2010. They also had a hospital here in Glenview, okay? And I live right there in Wilmette. All right, so this resulted in a lockup of the North Shore, okay, Chicago's North Shore. And then ENH, as they're known, Evanston Northwestern Healthcare, raised price. They raised price a lot. The number I'm giving here, 48% per patient, net revenue per patient day collected across all commercial payers. That does not include a ginormous increase to Blue Cross Blue Shield in 2004, because this study was done a little bit earlier. Okay? So at first they were steady with Blue Cross. They didn't raise price to Blue Cross at all, and they're the dominant player in the market. So that really is an understatement of how big the price increases were. The FTC decided to study them as part. They heard a lot of complaints. They decided to study them. Okay. Well, the insurers testified. They said, we have no choice. We had to go along with those price increases. The North Shore is very affluent. The executives of all the companies in the Chicagoland live there, and you know, they're making the decisions. Their HR departments are making the decisions. So we really need to have a presence, some sort of provider in the North Shore. And the insurers specifically said this, which the authorities love to hear if they're prosecuting anyway. They said, you know, we could have walked away if we had an option. Okay, we could have played these two off against one another, but we had no option. We couldn't walk away anymore once they were combined. Now let's get to the hot documents. Okay, hot documents, I learned this term. I thought they were called smoking guns, but they're called hot docs. Hot docs are documents that the lawyers love because they reveal some intention on the part of the other side. Okay, so there were lots of hot docs in this case. Including this one is a good one by the president of Evanston Northwestern. Some $24 million of revenue enhancements have been achieved, mostly via managed care renegotiations. None of this could have been achieved by either Evanston or Highland Park alone. The fighting unit of our 3 hospitals and 1,600 physicians was instrumental in achieving these ends. So this is what your antitrust counsel does not want you writing. Better yet, you don't think it, but they definitely don't want you writing it. Okay? And this was just one of the great tidbits like that. And then the economists, this is a little more boring, but I think important. The economists then testified, and they sort of tried to nail what had gone wrong in the other cases. Okay? Part of what had gone wrong in the other cases had to do with the market definition. Okay? So that means whatever circle you might draw around Evanston, Northwestern, and Highland Park, how big should that circle be, and how much market share do these players have in that circle? That's how old-fashioned antitrust is done, and it's a first screen. And the FTC would have trouble, and the Department of Justice and so forth, with that circle for the following reason. If it just tried to draw around the North Shore, it could be reasonably argued, but so many patients go to downtown to Chicago for some of their care, right? And therefore, these hospitals do compete with hospitals in downtown Chicago, and once you add in all those hospitals, they're tiny, they couldn't do anything. Okay? But now we know that not to be true. Okay, we know that they were able to successfully and quite profitably increase price a significant amount. Okay? So that way of using markets and using patients who travel to help define those markets, that is making sure that there is fairly limited outflow out of your geographic market, doesn't actually lead us to the right answers in the case of at least hospitals. Okay? So we have developed new methods that enable us to get at the substitutability of different hospitals that really have nothing to do with what a circle is around them. These are choice models that economists have developed, and we can basically predict with, I don't know how great accuracy, but we try where patients would go if a hospital was taken out of network, and if it was taken in network, and if 2 hospitals merged and you took them both out. Okay? And how the bargaining dynamic changes, because taking them both out at once is more harmful than the sum of taking them each out separately. Okay? So the combination of the 2 is what generates an increase in bargaining power. So some of this stuff, believe it or not, made its way into court and absolutely is used now in mergers. Okay? There was a trial. If you're sued by the FTC, most likely, not always, no lawyers here, I won't go into why, you're going to be in the FTC's courtroom, right? Department of Justice does not have a courtroom. FTC has a courtroom. You can show up. If there's a trial, well, I don't know if you can. I've been to a trial. Briefly, it's very boring. So the administrative law judge at the FTC ruled that the transaction was anti-competitive and said, you got to sell Highland Park Hospital. Evanston and Highland Park appealed, okay? And this was now in 2007 or 2008. Remember, the merger occurred in 2000, okay? So if you think trying to untangle hospitals that have merged together is easy, try to remember this. There's a reason that antitrust experts call this unscrambling the eggs, okay? Not so easy to do. And so on appeal, the commissioners listened to the case and said, look, this was an anti-competitive transaction, right? You violated the Clayton Act, but it's untimely now. You've made so many investments already in Highland Park Hospital that to force the divestiture would actually destroy value and be harmful to the community, and we're not going to do that. But we're going to make you negotiate separately. You guys heard of something like that? We're going to make you, if the insurers want it, meet in separate rooms with them and negotiate one price for Evanston and your other hospital that you had, which is Glenview, and one price for the newly acquired Highland Park Hospital. That's what happened. That was the proposed consent agreement. In the lunchroom, after this comes out, my colleague, David Dranov, many of you know him as an expert in antitrust and healthcare, and I are talking about this decision, and we're just scratching our heads. How could they possibly have ordered this behavioral remedy instead of a structural remedy forcing the divestiture. Instead, they say, well, change your behavior. Why don't you guys pretend you're not part of the same company and just negotiate separately? So we just, thought that was hilarious. And I went back to my desk, was doing my work, and my colleague made some phone calls, and he comes up to me and he's like, we can write an amicus brief. I don't know what an amicus brief is. I do remember what amicus means, so I guess I can get it. And so it's a friend of the court brief, and we can file during this comment period and basically tell them what we think of that remedy. And let me explain why we thought the remedy was so funny. Okay, so you've got two hospitals, right, that draw patients. Right, there's some overlap in the patients that they draw. Okay, so there's substitutes. The insurers told us they were substitutes, right? If they merge, even if they don't sit in the same room, okay, one has an incentive to raise its price a little bit, because if it gets left out, it knows that some of the patients that it loses go over to its sister hospital. Okay? And vice versa. That means that the price that ultimately gets charged is higher than it would have been absent the merger. Okay, so that this separate contracting doesn't eliminate that incentive to price higher. I'll give you another example because I think it's so important and pretty relevant here. The way that I like to explain this pricing internalization of pricing externalities is, to use the economist jargon, is to use the retail chain, The Gap. Okay? So The Gap's high-end brand is Banana Republic. I used to think that was pretty high-end. Right? Banana Republic. Banana Republic, and then middle of the road is Gap, and then under that is Old Navy, right? Okay, so if Banana's cardigans are expensive this year, I may say, well, you know what, I'm gonna look for them at Gap. Okay? And if at the Gap they're a little pricey, I may say, I just need it for this one dress, I'm gonna look at Old Navy, but I won't really, but anyway. Well, the idea is that Banana has an incentive to have more expensive cardigans because they know that some customers that are lost are not going to go just to all other rivals. Some of them are going to go down to their co-owned sister brand. Okay? So that just gives them an incentive, all of them together, to have higher prices. That's all that we're saying with the fact that even if you're pricing independently, even if Gap and Banana brand managers don't all get together and coordinate exactly on what the prices are of their cardigans, they have this awareness because there is a realization that there's substitution going on. By the way, as many of you may know, no insurer has ever taken these hospitals up on the offer of separate negotiations, so you can think about what that means for how valuable it must be. All right, so we file the amicus brief. David writes a draft, I edit the thing, and then he literally emails it out to whatever friends he can find that day to sign it because it has to be done quickly. Okay, so this might have been a longer list had we had more time. And this is as strongly worded as we could get, right? Because apparently, well, in legal documents, you're not that fierce. Right? So it says, if the United States is going to have a market-based healthcare system, it's critical to preserve competition. If the FTC takes its charge of protecting consumers and society in all markets, including healthcare, seriously, then the commissioner's E&H ruling is clearly a step in the wrong direction. Harsh words. Clearly a step in the wrong direction. Okay. Oh, it gets good. So months pass. Okay, and Evanston challenges our right to, legally, this is all posted on the FTC website, the right of economists to file this thing in the first place. I actually didn't know any of this, right? And I'm told that in part associated with the letter, the commission then imposed the requirement that insurers who sought it could go to arbitration. So if they didn't like the rates they were getting from Evanston or from Highland Park, that Evanston and Highland Park would have to go to an arbiter. So that may have had something to do with the letter, but I don't have firm confirmation on that. But what did happen many months later is I got something in my mailbox, and who goes to her hard copy mailbox not too often. One day I did go, and I saw a hard copy of the amicus brief attached to this letter from that same CEO of Evanston Northwestern, the one of the fighting unit. And he writes it to the president of Northwestern. And he says, Dear Henry, and FYI, in case you hear about this matter somewhere, our board management is not very happy at this moment. with Northwestern's filing of a brief with the FTC to reinstate the divestiture order on our Highland Park Hospital. And I should tell you that before I signed, I forgot to mention this, Dranov said to me, you know, you're an assistant professor, so if you do not want to sign this, you should not feel obligated. And I thought, you know, if you don't have academic freedom, what's the point of this job? So I signed the thing, and then I get this letter, okay? But what's best is he copies his response, which is so good. Dear Mark, your language to me on the enclosed note is very unfortunate. Northwestern did not file an amicus brief with the FTC. Private parties can sign amicus briefs. I have neither the right nor the inclination to stop them from doing so. Please inform your board, since you invoke it, of my response. That was pretty awesome. So score 1 for academic freedom. I still don't know that maybe I have filed some briefs since then. Okay, what about the defense? It wouldn't seem fair to dump all this without discussing the defense and then maybe dumping on it. So the defense said, well, when we merged, we discovered that our prices at Evanston were actually low relative to what Highland Park prices were, and Evanston's a better hospital. So that's no fair. We wanted to raise our price. Okay? That, by the way, is not a good argument to make if you go before antitrust authorities. But besides that, then the counter also was, well, but then why did you raise prices at both hospitals? Okay, oops. And then the second point was, well, we made a lot of quality improvements at Highland Park. This is something that is worth raising, that the authorities do take seriously. The economists there examined a whole slew of outcomes, every outcome you can think of that you could possibly get from claims data. Some select conclusions include the fact that after they opened a new cardiac program at Highland Park, this was one of the investments, the quality of care in cardiac deteriorated at Evanston Hospital. And they traced that back to diversion of expert resources to establish the new program, so that on average, patients in the area actually had worse quality of care. Now that was for a certain period of time, and you could say maybe over time it would improve, but that wasn't such a good thing. And obstetrics didn't do too well either, and neither did trauma. Things aren't looking so good, and they're certainly not justifying more than 50% price increases in the first instance. Okay. What happened later is also good. E&H broke up with Northwestern, or Northwestern broke up with E&H. There's more to that story than just this. And E&H renamed itself their North Shore University Health System. And I don't know how they get a university, but guess what university they're affiliated with? Chicago. All right. But they wisely don't have Chicago, University of Chicago in their name. Okay? Now the FTC gets to receive and turn down proposals for behavioral remedies all the time, where parties want to merge and they say, okay, well, we'll sit in separate rooms with the insurers if they want us to. And then North Shore bought another hospital. I don't know if you remember the geography, but Skokie is right in that area. They bought Skokie because why not? And very recently, in the last few weeks, North Shore announced a merger with the largest hospital system in Chicagoland, Advocate Healthcare. They are to be named Advocate North Shore Health Partners because they want to be just like you. All right, so let's get on to some of the myths. I have 3 antitrust enforcement myths and 1 Affordable Care Act myth. All right. I promised some background, and I'll try to go through it fairly quickly. But the key antitrust enforcement agencies, there are 2 federal agencies, Department of Justice and the Federal Trade Commission, and that is an anachronism, okay? They both exist, and maybe if you were designing it in the first place, you wouldn't do it that way, but they both exist, and they're well-behaved duopoly. So they don't fight very often. Sometimes. They don't really fight too often over cases. One gets it, one doesn't. Department of Justice does all criminal stuff. They do all transportation. FDC does most healthcare and can't do anything with insurance. Actually, that's a really great story, so I'm going to have to tell it. Do I have time? No, I don't have time to tell it. Great story, another time. All right, but they can't do insurance. They enforce these statutes, and I put them up here because they're actually fairly limited. Right? There's a broader one the FTC has, but they very rarely use it. So the Sherman Act, Sections 1 and 2. Section 1 says no agreements and restraints of trade. Okay? This is where the doctors had some trouble for many years, and I couldn't believe it, but a set of nephrologists had trouble with this when I came even, when I spent the year there in 2012, 2013, which is independent practices getting together and engaging in a joint boycott. Or together saying, you know, we do not accept this price, and we're all going to only agree to this price. That's called price fixing. It's not allowed by anyone, not doctors, no one. Okay, so that's Section 1 of the Sherman Act. No cartels, that kind of thing. No meeting in the parking lot and saying, I'm going to bid this, and you don't bid on that. Section 2 is no predation or exclusionary conduct to obtain or maintain a monopoly. Okay. If you are a monopoly or have some monopoly power in a market, that's not illegal. Okay? So long as it wasn't obtained illegally. You have a superior product, more people want to buy your product, they're not buying other people's product, great. But if you do something exclusionary to prevent rivals from potentially competing in that marketplace, that's not okay. So if you go and acquire all of the input providers for your sector, okay, so that nobody else can make that product, that would be exclusionary, that would be anti-competitive, right? And then the Clayton Act, this is the one that is implicated in mergers. No acquisitions where the effect may be to substantially lessen competition. Okay? This will become relevant, I promise. All right. As far as studying mergers, the federal agencies are required to review those that are at least of some size, okay, maybe 70 million, 80 million, and there are a couple other requirements. Nonprofits have some exemptions. Okay. What does that mean? It just makes it a little more complicated. The federal agencies could still choose to review these combinations, but the combination doesn't have to wait for their review to come out. The parties don't have to wait for them. It's not on the agency's time frame. And the state's attorney general often will start an investigation. They might do a whole thing without getting any federal agencies involved. If it's something big, often both are involved, and sometimes just one is involved. Okay, and outcomes, they might do nothing. They might file a complaint and a settlement that they've agreed upon. Okay, we saw that with the partners' proposed acquisitions of South Shore and Hallmark recently. Or a complaint could be filed and they say we can't agree to anything. And this often happens, or it has happened with hospital mergers, because in some cases, say pharmaceutical company mergers, they merge all the time. They have a whole list of patents and they compare the patents and say, you know what, you've got 2 drugs in the exact same therapeutic area, or you've got the branded and you've got the generic. We're not going to allow combinations in that horizontal exact market. You're going to have to divest some of these patents. You can do that. But with hospitals, like divesting, you can't really divest a piece of a hospital, or maybe some outpatient facilities or some outlying facilities. Okay. Myth 1. I think the graph does it. Antitrust enforcers block a lot of mergers. 2012 is not special. That was the year I was there, okay? All right. Myth 2. Antitrust enforcers don't consider efficiencies arising from mergers. Oh, I wanted to animate that. So it is often stated, and I'll get to a quote from this gentleman in the Wall Street Journal. The CEO of Mount Sinai Hospital wrote a couple weeks ago, somebody, and please, if you ever run into things like this, send them to me, because I don't always catch them. Somebody sent me an op-ed from the Wall Street Journal. The CEO writes, here's all the reasons that hospital mergers are great. We'll get a nice quote from this guy. But part of that was as a defense against all these claims that hospital mergers are all about raising price. Okay? Many hospital executives believe that hospital mergers are actually about gaining efficiencies, that is cost reductions and quality improvements and streamlining care and aligning incentives and all of that good stuff. Okay? And they will say that the antitrust enforcers who are coming down on them are not paying attention to those efficiencies, and they're not listening. And so here is let me start with what not to do, okay? So what not to do, this merger was just announced. Remember Advocate and North Shore? I just told you about it, the biggest system in Chicago. Each of us has always been focused on reducing costs, but we have the luxury of time now to analyze the operations for efficiencies, okay? You're supposed to think about the efficiencies from your merger before you propose the merger, okay? Right? And then this one, that was great. This one I had from last year. There was a merger in Dallas, Scott and White Health System, I think in Temple, and then Baylor, which is in Dallas. They merged. Now that we're merged, we'll more closely evaluate opportunities to gain efficiencies. So these sorts of remarks might lead you to question whether efficiencies were a motive of the transaction. Okay, plus, let me be specific about what efficiencies are credited in antitrust enforcement. Okay? For an efficiency to actually be credited, okay, it has to be merger specific, okay? Where merger specific means it was very unlikely to have occurred or unlikely to have occurred but for the merger and cannot be achieved through other means that have fewer anti-competitive effects. Right? So we're going to merge, we're going to bring in the consultants, we're going to cut down our staff. Well, could you do that without merging? Right? So those kinds of things. Some of it, no. Suppose that you had 2 back rooms doing laundry or 2 imaging centers. There's some things that are clear, right? And some things that maybe are really not merger specific and the merger is going to create an opportunity to do some of this reorg. That doesn't count. That doesn't count. That's in the horizontal merger guidelines, which is a better read than you might think and easily available online. Okay, and it has to be verifiable. This is important. It has been hard for healthcare entities to satisfy. So efficiency claims will not be considered if they are vague, speculative, or otherwise cannot be verified by reasonable means. Okay? Let me give you an example. Now, this is from the Wall Street Journal, so I am officially stating it's not fair for me to put this up here, but it's the kind of claim that I saw when I was at the FTC, and you get what's called a white paper. Okay? So parties propose a merger, and if the FTC is investigating, they will often submit, their economics experts and their lawyers will submit separate or joint white papers to you saying, this is why our merger is so great. Okay? I was the deputy on a large merger of glass container companies. Okay? These white papers said, this is how much soda ash we're going to use at this plant. This is how much soda ash we used before we acquired the last plant we acquired. Here's the change. Here's how long it took. Here's how much money we're going to be able to save. This is how we're going to re-optimize the factories. We're going to manufacture our beer bottles here. We're going to lower our transport costs by this much because fuel costs this much. Right? They're studies. Right? They're studies. We get stuff like this from the healthcare companies. Population health management means services must be coordinated. This requires hospital systems to provide a full suite of services for their patient populations, warranting expansion through acquisitions of other hospitals as well as physician medical practices and outpatient clinics. It just doesn't have the same weight. Okay, and I saw Ashish walk in. I was so glad to read this article that was in JAMA over the summer because it's something that that is important for a quality expert to say. But consolidation is not integration, right? It could be, right? But clinical integration requires meaningful data sharing, systems for effective handoffs, streamlined care transitions. These processes can be achieved through other mechanisms. And that speaks to this issue of something being merger specific. If you can, in fact, coordinate with independent physicians, okay, which I think I'm going to get to a quote. Yeah, I'm going to get to a quote. If you can, in fact, do that, then your efficiency is not merger specific. And you could still go forth with that transaction if it's not going to have anti-competitive effects. But if it's going to have anti-competitive effects, right, you potentially could be sued if those efficiencies aren't cognizable. Okay? So there are real standards for that. All right. Continuing, it's actually not just enough for the efficiencies to outweigh the anti-competitive effects because there's the question of pass-through. So maybe I'm going to, by acquiring someone else, be able to get enormous economy of scales in production. Okay? Now I'm a monopolist. Why should I pass through those savings? What share of those savings am I likely to pass through? Okay, so you kind of have to multiply the efficiencies by a pass-through factor, argue about what that is. The guidelines say that if the anti-competitive effect is big, those efficiencies had better be very big, okay, because we err on the side of competition, favoring competition. Okay? And as I mentioned here, if you don't have rivals, why pass on? Myth 3, antitrust enforcers will be able to ensure competitive markets. I don't think that we really believe that. Okay? All right, they enforce the laws, and the laws are pretty narrow. Let me give you an example of how narrow. This is kind of relevant, I think, in this area. Suppose that there's a dominant hospital system, acquires an outlying community hospital. Suppose that that dominant hospital system was constrained in its ability to charge the price that its market power should enable it to charge because of maybe political fallout or something. Acquires this outlying hospital, raises its price. Now, that acquisition enabled that, okay, because it, say, didn't face the same political ramifications of raising its already really high-priced hospital, but because there was no substitutability of these hospitals, let's suppose, hypothetically, it did not, these increases in price did not result from a substantial reduction in competition, okay? It actually was just a combination that facilitated the exercise of pre-existing market power. These laws are narrow. It says, prohibits acquisitions that lead to a substantial lessening of competition. What I just described now did not lead to a substantial lessening of competition. Now, I will say there are some in the enforcement world who think that could be argued as anti-competitive, but there are many who do not. And the point is that the laws are fairly narrow, that you're having this discussion, okay? So of course, enforcing antitrust laws, even if they had infinite resources, which they don't have, and it's not easy to get all the way, a case all the way through, is not going to ensure competition. Then let's add some fact that they've got tons of legal precedents, they worry about these. If our case isn't super strong, okay, you might say, well, go for it. You shouldn't win all the time. If you're really trying, you shouldn't win all the time. They say, but then we set this precedent. And anything that is decided against us in this case prevents us from bringing further cases, causes other decisions and consent agreements we have to fall apart. So they have reasons to be cautious. They're cautious. They're deathly afraid of losing. Okay, that might be an interesting psychological study. So we need some industry leadership. Things like the Health Policy Commission. We have some members here today. To actually study what's happening and what the effects are and not be saddled by all of this baggage that the antitrust enforcers have. And that is not to say at all that they don't do a good job. In fact, firsthand, I experienced very, very talented people working very hard to protect consumers, but they can't ensure competition. All right, and myth 4, I think we can dispense with fairly quickly, that the Affordable Care Act encourages provider consolidation. Okay, so I'll tell you a story, but let me first give the words from CMS, Centers for Medicare and Medicaid Services. Okay, the final rule. They say they challenge this idea that in order to be clinically integrated, you have to be financially integrated. And they say we reject the proposition that an entity under single control, that is an entity formed through a merger, would be more likely to achieve the three-part aim. They explicitly say, we're not telling you, go out and all merge to be ACOs. And we reject that. In fact, their proposed rule had a mandatory antitrust review, which subsequently was removed. But they were not saying, hey, free pass, mergers for everyone. What's interesting is that case I told you about in Nampa, Idaho, the one I can't get out of my mind. Well, the CEO, no, it was actually the general counsel for that dominant healthcare system was quoted as saying, look, the government's talking out of both sides of its mouth. One hand, they say, integrate, and on the other hand, they say you've got to compete. We're saying, right. Those things are not inconsistent. They didn't say you all have to consolidate and own everything in order to be integrated. And in fact, during that trial, the vice president of payer relations, who formerly was part of Advocate Health, which is actually well known for managing care, risk-based contracts, testified that they were able, through Advocate, which has both salaried physicians and independent physicians, that they were able to develop mechanisms to reward their independent physicians to meet quality metrics and align with their incentive. They don't have to own their physicians, is Advocate's view. And the ACA explicitly does not exempt collaborations from antitrust laws. Okay, I will skip this quote and get to the unknowns, okay? Had to put up Rummy. There are things we don't know, Unknown unknowns. So let's talk about the known unknowns. Okay? I alluded to this earlier. We don't know very much about non-horizontal consolidations. The physician-hospital alignment is one of them. It's also, though, those hospitals in different markets. Okay? It's the combination, say, of a pediatric hospital, adult hospital. Clearly, these things, these entities don't treat the same patients, but could their combination increase bargaining clout? And if so, how? Do you think about that? And what's the limiting principle? If different products, then do you say, well, you know, any combinations of star providers could potentially be anti-competitive. Similarly, you could think of geographic boundaries. So imagine that there's, in every state, a chain that has 1/3 market share. What if it was the same chain in all those states? Would you think that they had more market power? Okay? And if your answer is yes, then where do you stop? So if somebody in California that has a 1/3 share wants to merge with somebody in Maine, is that okay? And how close can they get and how many can they have? And you can start to see there being some concerns about how you define that, okay? So we don't really know the answers for the effects and what are the sources of bargaining power in these sorts of transactions. Okay. The big picture, the really, really hard questions are, well, what would be optimal? How would you organize this crazy world of healthcare delivery that we have? Would you have Walmarts for most things and then have small niche places where you can go for certain conditions? So would you do more regionalization perhaps? But what about the convenience and patient compliance associated with that and personal relationships and continuity of care? And how does that vary based on the patient segment and the conditions that they have, right? So all this big think stuff that we get to think about, but ideally we would like the market to decide. You know, like the market decided that small bookstores were, you know, they'd rather just buy stuff on Amazon, right? We'd like the market to decide this sort of thing. The problem is that we're going to need better shoppers than we have. Shoppers that have information and that act on the information, and we have intermediaries. So it's not going to shake out like bookstores. Okay? And then a related question is, how would we organize the entities that are delivering healthcare? Okay, so one notion that I think is appealing is that physicians might be on top of a hierarchy and they would treat the hospital as a cost center because that's what it is. Right? But you have to ally with them in order to make sure that they don't have some incentive to try to defeat those attempts to diminish hospital admissions through introducing other revenue increasing opportunities. You have to ally and share in the savings. Okay? What about the insurers in all of this? Okay? I think that they have a role, not just in risk management, but also in aggregating across large populations and mining that data. So what do they do? And I'm really posing questions because I can't possibly imagine that you would want me to talk for more than one more minute. So I won't even try to answer these questions. But I would also say that, you know, I agree. We're not starting from ground zero. So I'm not really proposing that graduate students go off and think about, in an ideal world, what might US healthcare look like, okay? Yeah, don't go do that. But in that case, there are a lot of questions, which is, given that we're not in an ideal world, in a first best world, we're in the second best world, or third, or fifth best world, what sort of policies might make the most sense given where we are? And an example that I alluded to earlier, and I'll end here, is this issue of insurer consolidation, right? Some think that if we only had more unified payers, maybe even a single payer, but more unified payers, I'm not advocating for single payer, I'm saying more unified payers, that they could agree upon the metrics to reward, they could negotiate against providers' market power, and maybe get lower prices and somehow pass them on, okay? I guess I wasn't very fair in that characterizing that, sorry. All right, so some say that that's a way to go. Others disagree on that, but once you get into the world of the second best, anything is possible, and one size probably is not going to fit all.
All I can say is, wow, that was just an outstanding talk. Thank you very, very much. You did allude to a couple of activities around here.
Oh, my last slide, I forgot it.
Oh, your last slide. Show your last slide.
It's all about partners.
Oh, partners, right. So there we go. So while you're talking about partners, Stuart Altman is here, and I thought maybe some people in this audience might want to know what happened today at the hearing. And then we'll have questions. And let's see, you can talk for a minute.
And people say economists just talk about unreal situations. I'm David, maybe you should join me. So I think most of you have been following the events here in Massachusetts. And today the court, so the situation is that basically we've been having this interesting discussion on whether all the hospitals that surround this building should be allowed to sort of expand and add several more hospitals to their system. And while they've issued some strong arguments why they want to do it, the rest of the world has issued a fair amount of arguments that it's not such a good idea, and that there are all the problems that our good professor raised. So anyway, this was then, so the expectation was, well, all right, this would happen. Basically, the Health Policy Commission, which David and I are members of, we sort of been issuing fairly strong reports on our concerns about this, and I want to thank John and others for helping us. So we finally issued a whole set, and a lot of other people did it, sent it all into the Attorney General. The Attorney General packaged it all up and said, okay, we've listened to everybody, and basically we've come up with an agreement, and we're fine. Send it to the judge. The expectation was that the judge would say, well, we elected an Attorney General to protect the people of the Commonwealth, and we've listened to all this kind of things, and therefore we accept the agreement. I'm not going to get into the agreement. And the expectation was the judge would accept it. Well, the judge did not accept it. What she did instead was to put off for a period of time to allow another 21 days for people to comment about the last part of the agreement that had been modified, and then to hold hearings. I don't have the exact, do you have the exact date, David? November 10th. I think that's a little after the election. That has nothing to do with it, but I'm sure that was, that was probably the next free day she had. Anyway, there's going to be a hearing, and unlike in the past, others who have concern about this can have oral arguments. It's not just going to be the two parties, the Attorney General and the parties involved in the transaction, partners and the other hospitals. And so anybody, including many people in this audience, including you and your team, can feel free to join in and do it. We don't know how this is all going to turn out, but the impact of this. Now, one of the things I'll say, and then I'm going to stop, is that in the past, while the federal, and you talk mostly about federal, is that the federal judges can intervene and, in fact, do intervene in a very strong way and ask for outside testimony. In the terms of the states, there's not a lot of history of state courts, and there's nothing in the state law that required the judge to do this. So this is not a trivial issue at all. I think this whole agreement is up for grabs, and much of what you said is in fact the core to it, whether these non-structural changes can really affect the structure of this thing. And what you laid out was just fantastic. So for those of you who are watching this, for those of you who want to participate, I think the world is continuing. So I'll give this back to you.
Thanks, Stuart. So I don't know if this is unfair or not, but there are two individuals in the audience who are on opposite sides of this. Would it be unfair to ask Tim and Jim Roosevelt if they want to say anything? Jim Roosevelt, who's from Tufts, do you want to say anything?
It might be unfair.
It might be unfair? Well, he speaks. He
I will, though, in the Q&A section, I would like to ask a question.
Okay, ask a question. Tim Ferriss from the Mass General.
Do you want, Tim, do you want me to talk about this, or do we all know? We all know. Go ahead.
Well, no, you should.
Oh, well.
Because so far I have been riveted by everything you have to say, so I want to.
So the elephant in the room is the partners merger and mergers, and we haven't talked about it very much. And I wanted to make sure that I raised it, both because it dovetails with the issues I have been discussing, and because I co-authored a public comment on the transaction. So I brought for you a quote from Gary Gottlieb, head of CEO of Partners Healthcare. We've made a commitment to the Commonwealth and our patients to lead in improving healthcare quality and addressing costs. So there's an open letter. It was in the Globe recently, and it basically says we want to do good stuff here, and that's our objective. And I've also put a quote here from the Nobel laureate in economics, John Hicks, who writes that the best of all monopoly profits is a quiet life. And that, you know, the takeaway from that is not, oh, Gary Gottlieb, you know, you're feeding us a line. It's actually, oh, you know, Mr. Gottlieb, Dr. Gottlieb, there is, without market pressure to deliver results and to constrain costs, it is very difficult to achieve that, right? And when you have your physicians coming to you and begging for the latest, greatest, whatever expensive thing that it is, you will have difficulty turning around and saying, we can't pay for that because we're gonna lose market share to XYZ when there's no XYZ. And with that, which may or may not have riveted you.
Maybe you could comment a little bit further, but because that comment that you just made, I think is very germane to my question, which is, in that statement, the best of all monopoly profits. And I'd like you to speak to what you perceive as the perception of the of non-profit boards, who are the fiduciaries of a non-profit organization, who get nothing personal except the glory of serving on a board. It's an unusual definition of glory, but and why is it that they would give up their independence in pursuit of a merger in the face of all of the sort of current climate? What do you think is going through the minds of those board members? Why would they want to take on all the troubles that they've taken on in pursuing a merger, when in fact what they want is a quiet life?
All right, so let's start with the nonprofit so I can think about how to answer the next part. All right, so the nonprofit part as to the behavior of nonprofit hospitals, almost all of the research on hospital mergers has been focused on nonprofit hospitals because they're the majority, and the price effects that result are in that space. So the question of whether the board members, what is their incentive there? Maybe they don't have the same skin in the game. It can be difficult to when you don't have direct financial results you need to deliver. Exactly why the boards don't behave that differently from for-profits in the limited sample where there's comparisons, I don't know, but not-for-profits, the courts treat them the same, and empirically they appear to be different in only some regards, like the kinds of services they offer, burn care, psychiatric care. So there's some differences, but not enough that it would count as a cognizable thumb on the scale on the other side. Okay, and so your other question was, why would Partners Healthcare agree to take on this massive 82-page? No.
I'm sorry. So why would the nonprofits,
yes,
any of them involved in the transaction, why would the board members
agree to this if they didn't?
Right. What is their fiduciary responsibility?
What do you think?
You are the expert. I'm neither a lawyer nor an expert in.
I do feel I'm on camera too. Do you feel a little uncomfortable speculating on that? I'll.
Just to be fair, yeah. Barbara put me in the same situation.
That doesn't make it fair. I'll try to come back to that, but I will give you something, okay, that is a gentle way to answer that question. Toward the end of the comment, I wrote something that says, you know, there may well be parties in the community that are not in a position to object to this, even if they feel that it could be harmful to the community because they fear retaliation from expressing their view. Well, some weeks later, I get a phone call from a very large employer in some random town in America. A merger has been proposed in their town. The CEO wants to talk to me and says, that's exactly what we're in. I can't get other members of my Chamber of Commerce because they're afraid of upsetting the big hospital in town, and the board members are all linked and they all serve together on the same things. So that is, I think, a gentle way to answer your question, and maybe one-on-one, I may come up with something else. Ashish.
So, to just Tim's points, we did a survey of 1,000 hospital board chairs, asking them what are their priorities. And number one, by a lot, was financial performance of the hospital, right? By a lot. Quality wasn't in the top two for a majority of hospitals. So I know partners boards is different because they're focused on quality, and I'm making fun of it. But the bottom line is individual organizations, you know, may vary, but nationally it's very clear, right? Boards look at their fiduciary responsibility as financial health of my institution among nonprofit institutions. But I was going to use this as a question that I was going to ask you. You said ACA does not encourage mergers, and yet we've seen a real uptick in mergers, actually only among nonprofits. For-profit mergers have been relatively flat, but there's been this big uptick in nonprofit mergers. So even though explicitly Marilyn Tavenner says we don't want this to happen, why do you think it's happening?
It's happening because when you say, let's align, we need to align incentives to cut costs, the first thing that comes to mind is, oh, well, then let's all get together and we'll try to work on that. And if it doesn't work out, we can negotiate higher prices anyway.
There is maybe one other thing, which is the balance sheets of most nonprofit hospitals cannot tolerate the risk that is involved with signing risk contracts. And that's a non-trivial piece of the equation.
So the question I have, so I'm not supposed to be able, maybe I can't go back, just one. The question I have when I hear that about, well, we need to be, this CEO of Mount Sinai said that, well, we're not big enough, so we need to add a whole bunch more hospitals so we can do population health stuff, is show me the evidence on what the size is that you need, and then don't you actually need to get other providers in your vertical chain of production? Why is it hospitals? Why is it horizontal? And I get the last word.
If I may, I wanted to switch topics a little bit. So when I look at, listen to your story and I look at the numbers, I sort of feel like watching the melting of the Greenland ice cap on the one hand, and somebody's putting up a couple of windmills. Yeah, it's great that the FTC has won 6 after losing 6, but 60 merged, which probably represents at least 120 institutions. So that's not
and that doesn't even include the psych and rehab.
Right, so that's a non-trivial part of the remaining 1,800,
yeah.
2,000 independent hospitals every year,
yep.
falling into the ocean, melting straight from the sea level. So are you feeling at all good about 6? I mean, what's the future of competition in healthcare under that scenario?
No, I'm not really feeling so great about it. And worse is that too often the cases that are actually brought are a little bit like shooting fish in the barrel, only it's really hard. Like it shouldn't be taking months and months and months to get these years and years and years to get 2 hospitals in the same area that are merging to not be able to. I mean, it's to me truly astonishing. Now, as I mentioned to you, there's a lot of risk aversion in pushing the frontier and in interpreting the antitrust laws in a way that will be broader. So I don't expect antitrust enforcement to do much with I think they're useful, but they're not going to halt this wave. What would do it? Right? Well, HPC requires notices of material changes. If you have agencies that are tracking this and are putting together data and showing what are the associations, ideally what are the causal effects, and you have leaders of your organizations looking at this and saying, well, if this is what the data show, then I don't, as a leader of this organization, as a board member, then I don't think this is in the interest of my community. If more providers that are signing up to merge did their efficiency studies, and actually tried to figure out where would we put this and where would we do that, and how much money could we save if we did this in-house, and what's going to happen if we do provider-based billing. They actually did the math on it and saw it wasn't good. Maybe they wouldn't do it in the first place. But because so few of them are scrutinized, they do that like we saw from the recent quotes. They say, well, we'll merge and then we'll figure out what we can gain from it. So maybe if you hold them that standard, we might get informed leadership that is concerned. Oh, I'm sorry.
I'm Jim Roosevelt, and I'm currently the CEO of Tufts Health Plan and also the board chair of the Massachusetts Association of Health Plans, which includes all the health plans that operate in Massachusetts except for Blue Cross Blue Shield. And I wanted to comment on two things. One, with respect to what Tim was raising about why nonprofit boards consider mergers. At the time of the Partners merger, I was the board chair of Mount Auburn Hospital. And the board of Mount Auburn Hospital, you could call it fear for financial performance, but the fear was that the combination of was partners of Brigham and Women's and Mass General would put a Harvard community teaching hospital, Mount Auburn, in a position where it would not get adequate reimbursement from payers, and it would have patients directed elsewhere. And so the board felt that it had a responsibility to its community to preserve what it considered a valuable medical resource in the service area of Mount Auburn Hospital, and that would cease over time if the board didn't do something to strengthen their position. That's when they undertook merger with Beth Israel Deaconess, actually originally with Beth Israel, and then the Deaconess merger occurred in the midst of that, and so then Beth Israel Deaconess and New England Baptist.
Great answer.
That merger failed. That merger totally failed, and Mount Auburn ended up being up to now relatively financially and stable and with good clinical performance. So actually the fear didn't work out, even though the Globe Spotlight series showed that what the board feared did happen with respect to Partners and Blue Cross, the two dominant players on the provider and payer side, forming an alliance. And so that was the thinking of that board. The fear could be true in the long run, but over the last 20 years has not yet been true. However, from conversations I hear now, I hear that wave of fear happening again.
With physician acquisitions, a lot of hospital CEOs maybe don't want to buy all those physicians, but they're worried they'll be left with the lemons. Yeah.
And horizontal merger is an important piece of it as well. Now, with my current hats on, there's a split of approach to this in the payer community in Massachusetts. Blue Cross has refrained from saying anything negative about the Hallmark South Shore settlements. The CEO of Blue Cross was roasted by a Globe columnist a week ago for that. It happens that that particular columnist headed that spotlight team about the Blue Cross Partners collaboration 7, 8, 9 years ago, whenever that was, and has ever since resented that he was prevented from filing the last 2 articles in that series. He has also separately roasted Partners and so on. The quote you don't have there is a quote from one of Dr. Gottlieb's predecessors, as head of partners about 13 years ago, saying that the reason we formed partners was to get higher payments from insurers. And that is a documented quote from one of Dr. Gottlieb's predecessors. So you have the split among the payers today, where Blue Cross says Blue Cross is not taking a public stand. The other insurers filed with the court for the hearing today, and there were two parts to that filing. One was an analysis of the settlement as it was known up until prior to the Hallmark portion of it, an analysis of what the cost effect would be. And the other part was a more extensive antitrust analysis written by a well-known Washington antitrust lawyer, Art Lerner. So,
I know.
Yeah, you're sure. And so that's sort of where the landscape is right now. I think it is wonderful that this will be resolved after the election.
Does anybody, Tim, do you want to say? I'm sorry. All right, let's see, it's 5 past 6. We have time for a few more questions. David?
Well, I have a question that actually follows from Jim's first point, and that is, you sort of spoke about kind of bigger and badder. And it's very clear in the evidence where sort of number one gets bigger. You know, number one is charging higher price, and it's just either going to increase its monopoly position or allow it to let that seep out in other ways where it was constrained from doing so. But now in most big cities, you actually have a very big dominant provider. And so the question, and it really comes to Jim's comment, is bigger badder when you're talking about numbers 3 and 5 combining to be a number 2, which could challenge a number 1?
Not necessarily.
Is it? I mean,
it's not necessarily worse. You would say, so the question is, does the acquisition tend to lessen competition? And if it actually strengthens the ability of a competing provider organization to offer this suite of services, then the answer to that would be no. Even if, according to structural, adding up the market shares, it looked bad.
Do you have is there a sort of reveal in your mind, is there wisdom as to whether in general, if you've got one big firm, it's better to have other big firms, or in general, not better?
Good question. I was going to say, do I have any knowledge of cases where what you describe has occurred? I don't personally. It's a tougher sell than but I don't think it would be impossible to defend. And do I have a sense? Well, from standard models and from the bit of research in healthcare, we know that going from monopoly to duopoly, you get huge benefits, duopoly to triopoly, and so I would say that you would anything you could do to counter a monopoly would probably yield pretty substantial benefits.
Chernow and question.
So, except in the extreme cases where you're moving to monopoly, do you have any hope that innovation in benefit design or consumerism and search type models, stuff that's going on, can address any of these issues? Or is that just sort of bump in the wind, and in fact, there's no amount of sort of benefit design changes and information that can sort of...
Mike, it will surprise you to learn that I am opinionated on this. Here's what I think. I think that health plan competition is actually a very good mechanism for getting competition both among providers and for these benefit designs to actually work their magic in the marketplace. I am less optimistic about price transparency, about episodes and that sort of thing having an impact. So I think if we had a movement toward that separated employer-sponsored insurance and had individuals going around shopping for their insurance plans, that you would quickly find the market embracing both narrow network plans and benefit designs that involved, more thoughtful spending decisions.
One more question, and I think the hour's late.
Hello, my name is Jacob West. I'm a visiting fellow from the UK. So maybe a little bit of naivety given our market system, but I had two very brief questions. One is, what's the market here? So as I understand it, you've got nearly 100 or so super regional chains in some elements of the healthcare provider market. So isn't there a scenario in which actually they start competing against each other and the local market no longer becomes the appropriate geographical unit to analyse? And secondly, going back to my Econ 101, where are the new entrants? Can you speak to why new entrants aren't coming to this market if there's such significant profits to be made?
Okay, so let's take the first one. This is actually something that I'm working on with some co-authors, is thinking about how would you define the market? Is it a market for, say, hospital services? Is it defined by the end users? Or is it actually a market for network components? Okay? And in that case, then insurers are negotiating with various components and aggregators of those components and across multiple states. So this multi-market contact that you're describing could mean that even though services are consumed locally, that the market is supra-local, if you will. So I certainly agree with that. It is going to be a tough sell to antitrust lawyers. And then the second question is, why aren't we seeing entry? I think Zeke Emanuel says 1 out of every 5 hospitals is going to go under. Is that right? It surprised me, that number, but it's not attractive as an industry. I think the hospitals have capacity. Want to build a new one? He's not the CON. Yes, that's right. I don't actually think that, but they'll be more like utilities.
Well, I think with that, this has been an absolutely fabulous session, and the hour is getting late. I know a lot of people have kids and whatever to go home to, so I'd like everybody to thank Leemore once again for a fabulous lecture.